Hello everyone. Welcome to this webinar on mechanical circulatory support. I am Dr. Lalita, Assistant Professor from the Department of Cardiology and NIMS. And with me is Dr. Viswahnath,
Hello.
Senior Consultant Cardiothoracic Surgeon from Apollo Hospital, Hyderabad. Refractory circulatory failure resulting from organ hypoperfusion is associated with a high risk of mortality and morbidity due to multi-organ failure. The primary cardiac pathology is the leading cause of refractory circulatory failure. However, it can also occur secondary to sepsis and toxic ingestion. The conventional approach to a patient with circulatory failure includes reversal of the underlying causes whenever possible, mechanical ventilation, pharmacological hemodynamic support, renal replacement, and other supportive therapy. Mechanical circulatory support is an attractive option when conventional approaches fail. The potential benefits of the mechanical circulatory support are they help to maintain the vital organ perfusion, thereby preventing systemic shock syndrome. They help to reduce the intracardiac filling pressures, thereby reducing congestion as well as pulmonary edema. They reduce the LV volumes, wall stress, and myocardial oxygen consumption. They also help to augment the coronary perfusion. The final role, that is the limiting the infarct size, is still questionable with MCCs. The era of mechanical circulatory supports began way back in 1953 with the introduction of cardiopulmonary bypass, but it was only in 1964 that active developments in the mechanical circulatory support and artificial heart program was initiated. However, the major developments in this were done in the last decade only. So what are the available mechanical circulatory supports we have at present?
It's to start with, like the cardiopulmonary bypass. This itself is a circulatory support, but this is a very, very short time. Comes IABP, that also comes for short time. Then ECMO is there, that is extracardiac membrane oxygenation. That. Then SS devices, which changes from total heart to rights, which could be left ventricle, right ventricular, or biventricular. Now, these devices which are available, they have been actually for short term and long term. Traditionally, when it started, there were 3 generations of these devices were there. The first generations have a lot of limitation. Second generation, this is improvement. Third generation become more refined. Now, these devices, as we have seen, that IABP, ECHO, biventricular, that's S5000, AB5000, Thoratec, PVAD, and Centrimac, Tandem Heart, Impella. This Tandem Heart and Impella is more percutaneous devices. IABP, it works on counter pulsation therapy. ECHO is more like a cardiopulmonary bypass, and which is duration can be from days to week. We can.
So they are mainly for short-term support.
Short.
What are the devices for long-term support?
Long-term therapy is that left ventricular assist devices are there. They are like Centrimac, you can say. It can up to 1 month also it can come. Then left ventricular devices which are there. Like generation, if we say that the first generation was something like that, it was a pulsatile flow, this thing. But duration for this was small. Then came the next generation where it's a continuous flow is there. That can be available for longer time. Then third generation is that recent is that is a centrifugal and magnetically limited. This has been for long term uses.
Mechanical circulatory support is indicated for complications of MI, such as an ischemic MI or an acutely depressed LV from a large MI or a cardiogenic shock from RV infarction. For severe heart failure, be it as a severe exacerbation of a chronic heart failure or myocarditis, postpartum cardiomyopathy or stress cardiomyopathy. Acute cardiac allograft failure, post-transplant RV failure, prophylactic use for high-risk PCI, refractory arrhythmias, high-risk or complex ablation of ventricular tachycardias are other conditions where we need to consider the need for mechanical circulatory support. The ACC guidelines, the Heart Failure Society guidelines, the Canadian Heart Failure Guidelines, and ESC all have recognized the role of mechanical circulatory support in only one subset, that is, the advanced heart failure. When we mean advanced heart failure, we mean a patient who is severely limited with symptoms on minimal exertion or rest, with circulatory insufficiency, on inotropic support, or awaiting transplantation. According to the ACC and AHA guidelines, these patients in refractory heart failure have a peak VO2 of less than 14 with a 6 minutes walk test of less than 300 minutes. Many of them have cardiac cachexia, they are failing or intolerant of the conventional heart failure therapy, and they require repeated hospitalization for more intensive management. These patients will have a life expectancy less than 2 years without a heart transplant or MCS. How do you decide what patients of advanced heart failure are suitable for LVAD, sir?
There are like registries are there, that is INTERMAC, that is Interagency Registry for Mechanical Assisted Circulatory Support, which they have graded into 7 levels. The first 3 levels which are there, they are the clear indication there we have to use mechanical support. Of this, the first one, mechanical support, that is for acute failure, where there is no question, there has to be, we have to use urgently.
That means there is an immediate implementation of MCS should be there.
Yes, yes. And other two, like level 2 and level 3, they are actually, there's a progressive decline, and then the function, then this is like that, there is a sliding fast actually, and other than that we can wait, and the last like 6 and 7 we can consider later on.
That means in the Intermax classification, those with 1, 2, 3 are definite indications for MCS.
MCS. Now, these indications for that, it is that when we started, it was actually for bridge for recovery. Later on, it was extended like from this of recovery to this to transplant. And now, as the requirement has occurred, we are thinking for destination therapy. The fourth term like is that this to candidacy. That is that we allow for the heart transplant, but the vital organs are still deficient in the head. So we allow it to recover and then put the candidate for transplant. So these are 4 main indications we can see.
So we had a case which we wanted to take your opinion how to manage about it. Actually, he was a 35-year-old male that presented to our intensive care unit with congestive heart failure. He had history of acute anti-wall MI 6 months back, and for which he was thrombolized outside. An angiogram done then showed a recanalized LAD and other vessels were normal. The echo showed severe LV dysfunction and there was only mild LV. In the first admission, he was stabilized with inotropes and vasodilators and was discharged. The angiogram was again repeated in the same sitting to show the same finding, that is, the recanalized LAD and other vessels being normal. Subsequently, 2 admissions for failure occurred within the span of 1 month. So this patient was kept on the transplant list. And the last admission was failure and cardiogenic shock. This patient was not responding to the conventional pharmacological therapy. He was ventilated. We gave them the option of the mechanical circulatory assist, and due to financial constraint, finding an IABP was insane. However, we could not revive this patient. So we are sure that this is a patient of advanced heart failure, and he would definitely benefit by mechanical circulatory support. According to you, which could be the best modality of MCS for this patient?
Actually, it could be ECMO, it could be left ventricular assist device, as there is financial constraint, and he has suffered MI, and he has been listed for transplant. I think it requires a short-term therapy, so we can consider for ECMO.
Can you brief us about ECMO, how it is done, and what are the indications for that?
As it stands, that ECMO means that extracorporeal membrane oxygenation. Basically, it was started in neonatal and pediatric practice for a respiratory support, where the oxygen is delivered is there. Later on, they found that for carbon dioxide also they can remove it. But this too, the ECMO has been supported both for actually respiratory failure and cardiac failure both. In respiratory failure, normally we use venovenous. I think we'll stick ourselves to the cardiac failure, where we have the access has to be Veno artery.
Can
Means,
you tell us about the circuit and how the cannulations and
Yeah.
all are done?
This typical circuit has got a pump. That is a roller pump or centrifugal pump, depending on the pump design. Now, there are inflow cannulas there. That is that from the venous side. Venous side that we can put it on the groin or neck. There are large excess cannulas are there, which we will. So, basic component of a ECMO circuit is a pump, that is a then membrane oxygenation, then there is a heat exchanger, cannulas are there, and this basically is the basic design is there. Then above this thing, there are safety measures which are been added, so that we can see that this particular they have device which alarms are there that show the pressure alarms, that the battery alarms are there, then saturation alarms, all this thing can be set. So these are advanced systems. And now it has been made totally portable.
So what I understand by that is basically the venous access is for the oxygenation and respiratory problems, whereas the veno-arterial is for
Cardiac. So
how
now
is the procedure carried on?
procedure is that it can be done like the first thing is that it could be percutaneous or it can be that central. Now, percutaneous is that either we can go like open way in a groin or on the neck. We can cut open. Like in pediatric age group, like neonatal, they cut open. But as in grow a little older child or adult, it's a more a percutaneous, whereas Seldinger technique, where we just put a needle, pass the guide wire, and serially dilate and we'll put the cannulas. The cannula has to go into IVC, that hepatic part of the IVC can stay there, and other return cannula can be put into SVC. This is the percutaneous. Central, when we think about like any case where like cardiopulmonary bypass has been instituted and surgery has been done and recovery is not expected as so in that case this can be supported with ECMO in the central where the cannulas are still there.
The cannulas are still there, so we can go for a central.
Yes.
What about the role for anticoagulation?
Yes, this will, because as any standard, this is a cardiopulmonary bypass, it requires anticoagulation, that heparin is required, and normally heparin is that which we use 10 unit per kg body weight, heparin is given. And then we titrate this with ACT, which is activated clotting time, and keep it 1.5 times the normal. That is that it is in the range of 180 to 240 we keep it. And in case if there is problem with heparin, then we have to definitely think of other option like bivalirudin or argatronetin. Now setting up of ECMO unit, setting up that requires that we have to prime the circuit, means we have to that crystalline solution ringer lactate is there, that has to be, we have to go through that and put it into the oxygenator and fill it up, that reservoir, all this thing has to go. In a child, we can prime it with blood also. Once you blood it, and once the cannulas have been put in, we connect this cannula to the ECMO circuit. Now, once this ECMO circuit has been maintained, this we have to see that blood flow. That how much of the blood flow is required. That is, in a normal case, if we see that the oxygen delivery has to be at least 6 cc's per kg body weight has to be there. An adult requires a blood flow something like that 60 to 80, 60 at least he requires 60 cc per kg per. So that is required. So that the adequacy of blood flow also we can just with the venous saturation. If we see the venous saturation is showing above 75, means adequate perfusion is there. Apart from that is carbon dioxide clearance, we will not go into that. Basically, this ECMO is more a teamwork, where we require cardiothoracic surgeon, cardiologist, we require intensivists, like ECMO specialists are there, anesthesiologists, there is a role, great role for perfusionists is there to maintain this. Then apart from that, physician assistant are there. Now this teamwork is required for a drill and to see the safety about this, because many things can happen in this, like high pressure in the circuit because of a ping, there can be clot in the membrane oxygenator that can get blocked, or there can be air in the circuit, there can be clot. All these things have to be periodically seen. The clot has to be seen with the flashlight, this thing. So this is important. Now,
Once the setting is done,
yes.
what are the things we need to, other parameters which we need to check?
No, once we have to put this has to be put under sedation with light anesthesia has to be given, so that patient is not aware of it and doesn't move. Otherwise, there can be chances if they move, they can be airborne. So that we have to avoid. So that patient should be quiet during that period. Once that is done, and once we set this thing, we have to set the flow with a very low flow, and then go periodically go up to the normal optimized flow. Then what happens that during this thing we can see that sometimes we don't get adequate flow. That may be because of the hypotension, that is blood volume. In case maybe less. In that case, that we chatter and then return is not much. So the BP is not well maintained. The flow is well maintained. So in that case, we have to treat that hypovolemia with blood or volume placement. Normally we keep CVP around 5 to 10. Then again we have to see because it requires oxygen delivery also. So hematocrit has to be optimum, that is at least 40. Then temperature should be as close as to body temperature, that is 37 we keep it. Then other is renal and nutritional balance because they have been nutritionally very weak. So we have to look for that. Then positioning of the patient is very important, that it should not be moving too much, and then periodically we have to move from see that other problem should not occur. Bleeding is a very serious complication in this. We have to adhere because they receive a heparin. There will be platelet problem can be that be thrombocytopenia can be there. There can be thrombocytopathy can be there. All these kind of clotting factor they can be deficient. So bleeding is a serious problem. In that case, we can always think about giving blood and correcting ACT to the optimum level. And sometimes we may have to give like circulatory cardiac factors unless we can give FFPs to money.
What about the weaning mode once we are satisfied?
Once you are in where we are well, like in the cardiac, if you say the cardiac, at least we know that okay, respiratory part is taken care. Once we bring the patient to the theater or we have put it in the dialysis setup, we are confident that optimal flow is there and perfusion is well maintained. We see there's a good urine output is there, inotropic support is not much, and respiratory parameters are very good. We can wean them from the ventilator. And once we wean them from the ventilator, we can progressively come down the flows. We can clamp it and put it in the breeze. We can see that okay, that if they maintain very good, we can decamp it.
At present, what are the approved indications for institution of the ECMO support?
Mainly, they are only for a very short period. So we can say that weaning from the cardiopulmonary bypass after cardiac surgery, with bridge to cardiac transplant and acute myocarditis, where we expect the recovery is good. Then intractable arrhythmias, post-cardiac arrest like CPR. This can be used very well. And local anesthetic toxicity.
The main advantage of ECMO is that it can be placed at bedside with fluoroscopic guidance. And even the metabolic derangements and the systemic deleterious effects of cardiogenic shock, they are seen to reverse within hours of initiation of ECMO. But is that ECMO has no limitations?
No, ECMO has limitation. This has got complications are there. It cannot be used for a very long period of time. It's a short therapy is there. So it has got problem that you can have thrombosis, there can be bleeding problem, there can be infection, and then there can be embolism, air embolism, all problems can be there.
It was also seen that the major limitation was that due to the high myocardial oxygen demand, that was secondary to the high filling pressures and volume, there was an afterload mismatch and an inadequate LV decompression. It was seen that patients with low cardiac output and native low cardiac output and severe mitral valve degestation, these patients were at risk of developing pulmonary edema. So one school of thought is that along with ECMO, these negative consequences can be reversed by unloading the LV by concomitant IABP or internal.
Yes.
Are there any specific contraindications for ECMO?
Absolute contraindications are that unrecoverable heart and not which is not a candidate for transplant or bad, or advanced stage chronic organ dysfunctions, or the compliance is low, like financial, cognitive, psychiatry, social limited, or a prolonged CPR. In that, and we find that adequate tissue perfusion is there, this becomes absolute. Relative contraindication is basically anticoagulation, advanced stage, and obesity.
Evidence, actually there are no randomized control trials with ECMO.
I agree.
Okay. But it is mainly the ELSO, that is the Extracorporeal Life Support Organization Registry. This has shown that the chances of survival up to hospital discharge was 27% when this support was used in patients, adult patients with cardiac arrest. Similar reports by other authors like Nicole et al. As well as Gray et al. They showed that the cardiac survival varied from 25 to 55%. Okay. In one survey, it was shown that the cardiac survival rate was 45% for children and 38% for adults. In another study, it was shown that ECMO for emergency CPR was utilized in 41% of the cases. At present, the ELSO recommends that ECMO should be used in adult patients in cardiac failure for 4 reasons. One is inadequate tissue perfusion manifested as hypotension and low cardiac output despite adequate intravascular volume. Second, shock persisting despite volume administration, inotropes, and vasoconstriction, and IABP pulsation if ectropical. Cases of acute MI, myocarditis, peripartum cardiomyopathy, decompensated heart failure, post-cardiotomy shock, and sometimes septic shock, where the shock persists despite all the conservative methods. ECMO can be
You're true, because it should be a very short-term therapy. That's it.
What is your experience with ECMO in practice?
No, we have used about in 8 cases. Now, these 8 cases, they are both for respiratory as well as the cardiac. In cardiac acute respiratory failure, we have used for about 2 patients, which is a H1N1 influenza patients. And they were actually duration was 7 days average, and they recovered. Both they have been taken off from the ventilator. Their oxygenations were good, and they were discharged. Other 2 for cardiac, 2 patients we have used it in like high risk PCI, where the left main stenting was there, and they had comorbidity as well, right? So they cannot go for surgery. So they were for left main stenting. In that cases, it was used as a bailout procedure. So there we have used, and the both patients they did very well, and they recovered. Then 3 patients we have used. Actually, 1 patient that we have used for a post valve patient. That the patient underwent mitral replacement. She had LV failure, and with as a bailout we have see water, because anyway we are there and cannulas were there. We have put this ECMO, and we tried to solve, but we have seen that LV valve was too much, and as we see that it is was not helping. So in that case, we could not actually support it for a week or 2. So, but slowly the lady went into sepsis and then succumbed. Other 2 patients which we used, one for the lung transplant and other for the cardiac transplant. The lung transplant patient also did well for some time, but then because of immunosuppression, she went into sepsis and then had a problem. And cardiac was actually there that he had an RV failure. First he did very well for 10 days, he did very well. And slowly he went ahead to RV failure, and then he succumbed. Then 1 patient, I remember, this patient is actually, he came with cardiomyopathy, dilated cardiomyopathy. He was frequently getting admitted and having symptoms. Then he was put on ventilator, inotropic support, and then we went off from everything. Then again he went to pulmonary edema. Then we thought that he is a candidate for he requires a cardiac. He was a young fellow who requires a transplant. So then we use this ECMO as a bridge to transplant. So in this case, what when the short-term therapy was, we thought that anyway we have a lot of hearts which are available, we'll get it. So this was used. In fact, we used for 22 days. First time, 15 days, he did very well. He was so sick to admit. but he recovered. His functions were very good. His vitals improved, renal function improved, all parameters improved. So 15 days he did well. But later on, what happened? That slowly he started developing thrombosis of the circuit. That also we had to change. Then he went into sepsis, and then he succumbed to that. So because of non-availability of the heart, he could not.
So at present we can say that given its less invasive, natural peripheral, less invasive nature, the peripheral VA at home with attention to optimal LV afterload, minimizing the LV distension with optimal fluid and ionotherapy, anticoagulation and pulmonary management, it remains a viable first-line option for patients with isolated acute cardiac failure refractory to conventional management. This is another case. She was a 64-year-old female with severe aortic stenosis who had presented with refractory heart failure. The echo had shown severe LV function, LV dysfunction, and moderate VH. Coronaries was normal. The patient was planned for AVR. Patient had to be stabilized before taking her for AVR. Patient was on inotropes, she was ventilated, and finally she was taken for AVR. The AVR was done successfully, but the patient could not be weaned off the pump. What do you suggest in this case?
It's a really good coincidence. We also had a similar case where there was critical aortic stenosis. She had repeated episodes of failure. Her heart function was only 20 to 25% was there, and pulmonary hypertension was there. We are thinking about for doing aortic valve replacement. So we thought that in this case, when we did, then we opened and we could not come off bypass. Weaning was difficult. We thought that putting IABP, but IABP, as it has been seen that it doesn't very help is not very helpful in some cases.
So what did you do in your case?
No, we did actually. We put a CentriMag. That's CentriMag. That's the LV assist device, which is a centrifugal and magnetically levitate. This we put it actually, as it was anyway it was open, so all cannulas which were used for cardiac AVR, we could just aortic we connected to the return line, and venous line we could take it for this, and so we put the CentriMag. This now you can see the CentriMag. This is a line where we show that console we can see the flow rate we can mention. Now once we open, we connect it to the line, and this central mag that works on the that it rotates. So the RPM decides the blood flow. So optimal we have to think about that how much of this rotation we require for blood. Optimally we require normally 2.5, normal than 2.5 to 3 liter we require. So that can be achieved with a low RPM and slowly go up to higher RPM. And we have to see the adequate RPM and adequate flow for that. So this we have used this case, and we have seen the central, and then all lines here they have put it. After this thing we have shifted her to ICU, and once we shifted to ICU, we saw that her functions are doing well. She became awake, and once she was awake and her pulmonary parameters were very good, so we extubated. On the same next day, we extubated her, and then we watched for her hemodynamic. We could see that heart function was improving. We have seen both on echo as well as clinical, as the inotropic or requirement was coming down, urine output was improving, and blood pressures were holding with decreasing inotrope. Even the pulmonary pressures were coming down. So with that, we thought that now, and we slowly weaned her from. Then fourth day we could wean her from the CentriMag, and she did well. And
but why did you select the CentriMag in this case?
CentriMag, the thing is that one is that it's required for a very short time. We thought that, and second thing is that a cost factor also. The cost is little less, and anyway, IABP we know that is not going to work that well for us. So I think this should be a good option.
Okay. If not for CentriMag, what are the other options for this patient?
Oh, all options are there, from total heart to all ventricular assist devices are there. which are actually, we can say that some volume displacement like IABP, continuous flow pump, like axial flow is there, like your percutaneous impella, and tandem heart, which is a centrifugal one, which is also a percutaneous. It ranges from percutaneous to implantable and paracarporial, all is there.
Okay. At present, CentriMag has been indicated, rather it is approved only for RV support, that is as a humanitarian device exception. This was for temporary circulatory support lasting up to 30 days. Trials are being conducted for the use of CentriMag as LV device or as well as biventricular device. Whatever evidence we have at present is basically on predominantly the case series, and all of them have been shown that CentriMag is definitely an effective technology for temporary support of patients with cardiac and cardiorespiratory failure. As Dr. Viswahnath has said, other than the CentriMag, we have we have the LVSS device, which can be both percutaneous as well as implantable. Coming to the percutaneous devices, these can be either volume displacement pumps, such as an IABP, as we already mentioned, or there can be a continuous flow pump, such as an impella, which is an axial flow, or a tandem heart, which is centrifugal flows. IABP, we all know, it is the most commonly used form of circulatory support. Though theoretically, we expect that the hemodynamic effect of IABP is quite superior, such as it increases the diastolic blood pressure, decreases the afterload, decreases the myocardial oxygen consumption, increases the coronary artery perfusion, and enhances cardiac output. However, it is seen that none of the prospective randomized controlled trials have shown any benefit of IABP in cardiogenic shock. Even the IABP shock trial has shown that these patients did not do any better than those without an IABP. The CRISP AMI trial, this also showed that there was no significant difference in survival with patients on IABP and without IABP, but all these were in acute MI situation. IABP has a lot of limitations, contraindications, as well as complications. To summarize the brief and the present role of IABP in cardiogenic shock, we can say that because it is more widely available, it is less invasive, lower risk, it is easy to institute also. It can be used as a first-line MCS option, that is, it can be seen as a bridge between the conventional medical therapy and the other mechanical circulating support. One important role of IABP is that it can assist in the aortic valve opening in patients requiring peripheral VA, and they should not necessarily be removed. That means when you are installing the veno-atrial ECMO support, the IABP need not be removed from these patients. So, can you tell us about the implantable mechanical circulatory support?
Yeah, they range from total heart to ventricular assist devices. These ventricular assist devices, which are there, they have like three generations. The first generation, you see, they were more like a volume displacement, and they were having pulsatile pumping. This actually, that HeartMate 1, HeartMate B, HeartMate XVE. These were actually pneumatically driven or electrically driven. Here, these generation pumps were very big in volume. They have a bigger drive line. They have to be paracarporial. Somewhat they were, of course, implantable also, but they were very big and very cumbersome. Patient has limited mobility in this, so they were not used that much. Plus, we have seen them when they are put for bridge to transplant or bridge to recovery, their duration is not much actually. So this was the first generation. Second generation come where the refinement was there, where the continuous flow pumps were made available, which are axial flow, which are there. So this is like HeartMate 2, which has been widely used. Then these are actually very small. That design has become very small. This can be put in that's implantable. That patient can be more mobile with this. Now we see this particular this is HeartMate 2. We can see it has got a inflow cannula. Inflow cannula. This basically this has to be done under sterile precaution, it has to be done in operation theatre, where we have to do median sternotomy, go on cardiopulmonary bypass, put the patient by bypass. Then we have to pour at the apex small opening where the inflow cannula will be placed, and through this, then it is connected to the pump, which is in axial flow, and from there the blood will return to the ascending aorta. These are the way. Now, apart from they have a drive line, like we see this drive line is connected to a control unit. This is the brain of the pump, where every data is available, how it functions, this shows. Now this from control unit, this has got a backup which has to be connected to electrical device or to a battery. Now in this case we can see they have a complete portability, that the patient is holding a jacket with a battery, and this also he is holding, so he is more mobile. And they have shown in the REMAX trial also that has a very good result, that 1 year survival has been to the tune of more than 70, and 2 year survival nearly more than 60%. Now till this day, about more than 20,000 heartmate have been put in US, and they have FDA approval for destination therapy also. Now in our country also, of course our VNet we have not put it, we are in the process, but in country the centers we have put, like Chennai they have been put about 8 to 10 they have put it. Then there are Delhi also, there are 1 or 2 we have been put. Earlier some heartmates which have been put was by the earlier generation was put in All India Institute of Medical Sciences. Some were put in Narayan Hrudayalaya, which was with the Australian company, which were using, but somehow that was a very cheap option. But so over a period, what happens that they could financially, it was not viable. The company closed, so they also could not supply that. So this is the thing.
No, there is some third version, HeartMate 3,
yes.
I think.
That is the centrifugal one, and again magnetically levitate. So this has got advantage over Heart 2, that it is more refined in the smaller in size. Even the drive lines which are there, they are very soft. They can, and further refinement has been done that totally to get away with the drive line and go for transcutaneous energy transfer, so that it completely remains inside. So there is less chances of infection will be there. So, and more than that, you can see that in HeartMate 2, this is actually that is not near the apex of the heart. It is away from that. It's in the the abdominal quadrant it is kept. But in HeartMate 3, it's more near the apex of the heart. So like can be put into pericardial space.
What about the hardware device?
Hardware device is also like a third generation one. It is also has got centrifugal pump, and it has been widely used. But as for the FDA approval, it's not much. But
so
this has been used. No, this has been used for BIS to recovery, BIS to transplant has been used. As for destination, I am not very sure.
Just as the implantable LVSS device, we have the percutaneous devices, so especially the impeller and the tandem devices. The impeller is an axial flow pump which is designed to propel blood from the LV into the ascending aorta in series with the LV. There are 3 versions, the impeller 2.5, 5 and the impeller CP. This is depending upon the flow rate. Of these, the advantage is they can be placed percutaneously in the femoral artery. Of course, the 5.0 version requires a surgical control. The tip of the catheter is a flexible pigtail tip that stabilizes the device in the LV. The pigtail is connected to a cannula that contains the pump inlet and outlets. The impeller pumps blood from the LV into the ascending aorta, thereby unloading the LV and increasing the forward flow. It reduces the myocardial oxygen consumption, improves the mean arterial pressure, and reduces the pulmonary capillary pressure. More of experience is there with the impeller 2.5. However, if we come to the evidence, it is seen that though impeller was much superior to IABP, the results were similar to the tandem heart study. There was an increase in the cardiac index However, there was not much difference between the two groups when we compare the Impella to the tandem heart. The present role of Impella is mainly with the 2.5 device, and it has received the FDA approval for providing up to 6 hours of partial circulatory support, whereas in Europe, the same device has been approved for use for up to 5 days. The tandem heart, it is the left atrial to the aorta assist device. This is also a percutaneously inserted circulatory assist that pumps blood extracorporeally from the left atrium to the iliofemoral arterial system through a transseptally placed left atrial cannula. Both the LV and the pump will contribute flow to the aorta simultaneously. That is why it is known as a tandem. The major limitation with the tandem heart is the expertise with the transseptal puncture is required. Another important limitation is the requirement for an adequate RV function, that is, a concomitant RV assist device might be required to maintain the left atrial volume. Coming to the evidence, it was seen by Carr et al. As well as by Burkhoff et al. That adult patients with cardiogenic shock, when they were randomized to treatment with IABP or tandem heart, though treatment with the tandem heart resulted in a greater increase in the cardiac index, a decrease in the pulmonary capillary wedge pressure, but when it came to mortality, there was no difference in the 30-day mortality in both the studies. At present, we can say that the tandem heart has the FDA approval to provide extracorporeal circulatory support for up to 6 hours, and according to the CE for use up to 30 days. This device is primarily designed to provide temporary support, especially during the high-risk PCI in the cath lab, though some evidence has been there for its use successfully for post-cardiotomy heart failure as well as cardiogenic shock. When we compare the Impella and the tandem heart, there are only technical differences, such as the Impella is placed across the aortic valve into the LV for direct unloading, whereas the tandem heart is placed across the interatrial septum in the LV. However, no patient-level data exists to say that any difference is there between unloading via the left atrium or through the left ventricle. The major technical difference is the cannulation which is required. That is, we require a transseptal puncture in case of tandem, whereas Impella might require even a surgical vascular access. The 2011 ACC-AHA guidelines has recommended the use of these percutaneous mechanical circulatory support in the situation of MI in only 2 clinical settings. One is as an adjuvant to high-risk PCI. The second is for cardiogenic shock in patients presenting with ST elevation MI. Of course, there is limited evidence for the use of IABP. The role for Impella 2.5 device in high-risk PCI. This is by the PROTECT trial, which has shown that Impella provides superior hemodynamic support when used in high-risk PCI patients. The same thing was confirmed even in a large observational study. No randomized trials exist regarding the use of tandem heart disease in high-risk PCI. However, small series have shown that high-risk PCI which tandem heart support are successful with a better outcome. So the question is, when a patient in acute MI with cardiogenic shock in the emergency situation, which is better, IABP and Impella or something else? So in the normal situation, the IABP is often selected because that is the quickest and the most familiar one which is there. However, the Impella 2.5 or the CP version is better preferred in order to reduce the myocardial oxygen demand and improve the systemic perfusion, thereby avoiding systemic shock.
You see, even ECMO also can be considered in such a setting.
ECMO can also become. Now coming to this LVSS device, definitely none of them, they have their own limitations and complications.
No, actually, see, they have deloaded the failing heart and provided vital organ flow and improved them. But they are not without problems. There are problems, early problem, late problems are there. Like the bleeding problem is there, that on account of anticoagulation, then they have thrombocytopenia or coagulopathy can be the heart, that clotting factors can be deficient. That can lead to bleeding. Then other is right-sided heart failure. Right-sided heart failure basically that once the LV takes volume, that there can be shift of the interatrial septum or the interventricular septum. Or the other thing is that as LV is involved, there can be involvement of RV also. So there can RV failure is also known for that, and multi-organ failures. Then late is that bleeding. Now bleeding on account of, because we have to put them on initially with heparin and then later on to warfarin. This warfarin like induced anticoagulant induced bleeding problem can be there. We have to maintain a INR ratio in the 2.5 to 3.5. If it is becomes more, they can be bleeding. It can be from the any side. More than that, we have seen that because of continuous flow technology, what happens that they develop AV malformation. This more happens in the gut, so they can have bleeding from the gut. They can bleed anywhere. They can bleed in the brain. They can go to stroke. This can be proper. Other is thromboembolism. Thromboembolism is that basically is from the thrombus can be in the pump, which can go into the systemic, can go and create stroke, ischemic, other places ischemic organs, and this can be there. Then other is infection. This infection basically from the drive line, at where the drive lines are there you can the skin, it can go. They are basically more staphylococcus. And other is that gut and urinary, they can get it. So there, and as the systemic, you have to be very careful to see all these issues. That's why it requires a team again approach. A coordinator is required who can see all this once the patient is there. Like once we do this transplants, we have to bring them to our ICU. It takes about 6 hours from in the theater. From there, about 4 to 5 days they stay in the ICU. Then to step down, they go to step down. From there, they will be discharged. All this, once they are discharged, many aspects have to be seen. Their nutritional aspect, their this coagulation aspect. There are problems related to them there that they develop hypertension. Then once this is a continuous flow technique. So what happens that you cannot measure blood pressure. So you have to know blood pressure out. You have to have ultrasonic detection can do that. So that has to be seen. Then these patients, they have arrhythmias. That could be existing. They have been on some cardioverter defibrillator. Then again, it has to be managed. All these things, issues are there.
These are all about the LVSS devices. Other than that, we have specific right-sided support and even the total artificial. RV failure that is refractory to medical therapy. The options for these include a surgical RVAD implantation, veno-arterial ECMO, of course the cardiac transplant, and a total artificial heart. Historically, the percutaneous mechanical support for RV failure has been limited to the IABP, which only indirectly benefits the RV function by reducing the LV afterload and enhancing coronary perfusion.
So in this case, like right ventricular support, this like what we use for LVAD, if we put it into pulmonary artery, then it becomes a right ventricular support device. No? Like instead of aorta, and we put into the right, take from the RA, put it into pulmonary artery, that becomes RVAD. So that can support. Similarly, ECMO is there. ECMO we can see veno-venous. That can offload. Again, it can provide the right ventricular support.
Of the available options, the tandem heart is not FDA approved for use as a RVAD. However, now the latest, the Impella RP. This is a catheter-mounted axial flow pump which is undergoing evaluation for the management of RV failure. What is your opinion for the final about the total artificial hearts?
The patient comes with the biventricular failure. Option is either transplant or total artificial heart. Clinical use of total artificial heart has been much slower. In 2007, Intermac database reported 22 pulsatile intracorporeal total artificial implant, which has increased to 66 by 2013. Total artificial hearts are only used when absolutely necessary. The lack of long-term low wear device with small wearable component may have contributed to slow uptake of total artificial heart. There are many devices, artificial hearts there, like Lalita, Kule, Akutsu 3, Aviokar, Berlin Heart, Carmat. These devices, which have been used, are in very few patients and have been reported as case reports, and not some of them are actually out of picture. The only total artificial heart which is currently available and for which there is substantial clinical experience is one Syncardia total artificial heart and another is Aviocor 2. So Aviocor 2 is a pneumatically driven, has been used, and some 15 patients it has been used in 15 patients, but its approval has been on humanitarian ground. But Syncardia, total artificial heart, has been implanted in 1,250 patients. And the longest patient which has been supported by Syncardia total artificial heart is 1,374 days prior to receiving successful heart transplant. Total artificial heart, it eliminates one, symptoms. Second, as LV and RV are removed, so the source of end-stage biventricular failure is also eliminated. Third, arrhythmia. So requirement of pacemaker and defibrillator is also avoided. NAGM in 2004 has reported 10-year pivotal study and which led to its approval for use as bridge to transplant. 79% of patients who have received this Syncardia total artificial heart have been bridged to transplant.
To conclude, the mechanical circulatory support definitely provides superior hemodynamic support compared to pharmacological therapy. Patients in cardiogenic shock, they represent an extremely high risk group in which the mortality remains high. So the early placement of an appropriate MCS should be considered in this patient. Of course, we know that IABP is less likely to provide the benefit. It is better to go for the continuous flow pumps such as the Impella CP or the tandem heart or the LVSS device. ECMO can also provide benefit, especially for patients with impaired respiratory gas exchange.
Patients with advanced heart failure who are not helped by drug and surgery often need to stay in hospital or receive heart transplant. Both hospital-based treatment, but hospital-based treatment such as IVP, ECMO and IV drugs are unpleasant and confining. And for many ill patients, transplant is not an option. MCS and implantable total artificial heart are new options. ECMO in patients with acute respiratory and cardiac failure is a reliable form of mechanical support. ECMO devices are often located in ICU. Newer assist devices are more reliable. Improved designs allow use in smaller frame like Asian females. Newer designs have shown decrease in the risk of bleeding and infection. Mechanical circulatory support can serve as short-term therapy in form bridge to recovery, bridge to transplant, and bridge to destination as permanent solution.
We consider for isolated acute right ventricular failure complicated by cardiogenic shock. However, still registries and randomized controlled trials comparing the different strategies in different clinical scenarios are critically needed. And to conclude, in the emergency situation, analysis has shown that the percutaneous mechanical circulatory support are more cost effective compared to the surgical ECMO or the VAD support, and even for elective use in comparison with IABP. However, we need further data which shows a comparison of the different mechanical circulatory support. What do you want to tell our audience? Any take-home message from your side, sir?
Message is ECMO in ICCU is useful in selected subset of cardiogenic shock. LV or in post-cardiotomy cardiac surgery patients. LVS devices are approved bridge to recovery and transplant. Total artificial heart is approved for temporary bridge to transplant. A number of other ventricular assist devices and total artificial hearts are in development, and eventually they may offer an alternative to cardiac transplant. Registries and randomized control trial comparing different strategies in different clinical scenarios are critically needed.